The snappy title of the evening is Chronic Pain and Addiction and Chronic Pain, because there are two very maybe separate patient groups that we are considering. What are the issues involved in managing these patients, and actually how are we doing in Glasgow? Are we doing things well, or are there things that we can possibly do better? So I'm going to set the scene. I've only got 15 minutes, and then we've got a double act from Katrina and Sean McBride-Stewart, who have been working very hard trying to get an idea of the incidence or the number of patients in primary care who are on drugs associated with addiction. And then Jackie Peacock, who is sitting at the front here, who's one of our nurse specialists working in the chronic pain service at Stob Hill, is going to give an overview of an audit we did within the chronic pain service of the number of patients that we saw who we felt possibly there were some issues with dependence on their medication. And then finally, from the other perspective, Trina Ritchie, who, sorry, I can't actually see any of you, who's there, is going to talk about addiction or chronic pain in patients with addiction and some of the difficulties along with that. So it's, you know, it's quite a difficult subject. It can be a difficult group of patients to work with. So we hope that there'll be lots of discussion and questions in between talks. And certainly after Katrina and Sean's talk, we're going to have questions then, because Sean's got to nip off and get the train back to Edinburgh. So what I'm going to do is just try and set the scene if I can. So I'm going to talk about chronic pain. See if this reaches up here. Chronic pain is kind of the reason why we're here. Many of you work within the chronic pain service or work in primary care and see a large number of people who have chronic pain. The prevalence is high, almost 1 in 5 people, although not all these people will go to their GP or present to other primary care professionals with their pain. And there's interest in reterming it, the people that we may see in the pain clinic, as people with problematic pain. So it may be part of another disease or illness, so it can be difficult to define, and that may be why patients don't ever come near a secondary care pain clinic, or there may be no diagnosis or no medical diagnosis for the pain that they have. And it can be difficult to manage, both for the patient and for the healthcare professional, who maybe can't meet the expectations that that patient has in being able to either cure the pain or make it more manageable for them. And as a result, we see a lot of patients, certainly in the secondary care pain clinic, who have a lot of disability, reduced function, and not really a very good quality of life. And as such, it's quite a big problem, and it's receiving a lot of interest, both locally and nationally, both in medical circles and in patient circles and in political circles as well. So that's kind of why we're here. Now, if you want to see a very maybe bad stereotype of somebody with chronic pain, then you can look at Little Britain, and this is a bad stereotype. And what I would say, I've put down the bottom there, is as doctors or health professionals, we're often trying to diagnose an illness and treat it with a medicine or an operation, with a medical model of managing that problem. Chronic pain doesn't always fit into that medical model, and that can be part of the problem. And how somebody presents with their pain depends on lots of factors, some of which are in these bubbles there. So everyone's presentation is different depending on these factors, and genetically we're different as well in how we respond to a given pain. And what I would say is that pain is a subjective experience, and there's no objective measures. And that's relevant to what we're talking about tonight, because it's very difficult for us to have an objective measure as to whether we are managing somebody's pain well, whether we're actually providing pain relief and improving quality of life, because there's not a blood test or a X-ray that we can do which says we've improved the situation. And from the giving medication point of view, it means that you can give an awful lot of medication and have difficulty telling whether you've made overall a big difference to that patient. So that's why I've put that slide up. So if we're thinking about the medical model of managing pain and managing chronic pain, then there are many drugs which are used to try and relieve pain. And we often try and break pain down into different types of pain, whether it be pain from tissue damage or neuropathic pain, and there are different drug treatments that might be used for different types of pain. The main group of drugs when we think about addiction are the opioids. But as I was just having a chat with Ivan before, there are other drugs which are used to treat pain which are becoming drugs of abuse as well, such as some of the anti-neuropathic agents, gabapentin and pregabalin. So many of the medical treatments that we use to treat pain can actually cause a patient problems as well. Over recent times, over the last 10 to 15 years, the prescribing of opioids for non-malignant pain increased and increased, both in the UK and around the world. And there was almost a feeling that doctors were being opiophobic. They wouldn't prescribe opioids for fear of addiction, and they were denying patients adequate pain relief. But over the last 10 years or so, the kind of tides turned, and people have started kind of alarm bells have been started ringing about some of the situations that patients end up in, sometimes on very high doses of opioids, still reporting very severe pain, but with lots of side effects secondary to their opioids, and having great difficulty ever getting back out of that situation. The published evidence for opioids for non-malignant pain isn't fantastic, especially in the longer term. We prescribe them because we hope that we will improve somebody's pain, and so that allow them to have a better function in their life, improve their sleep, and have a better quality of life. But the actual monitoring of a situation can be difficult, and 6 months, a year, 2 years, 5 years down the line, it's unclear as to whether that particular group of drugs helps the situation. And there are concerns about tolerance, dependence, and addiction. And I don't claim to be an expert on addiction. This is somebody else's slide. We give drugs to try and as a therapeutic agent, but if patients continue to take drugs with no therapeutic benefit, then you could argue they may be dependent on the drugs, and if they are suffering harm as a result of being on the drugs but still take them, then that could be addiction. There's been, over recent years, a great increase in the manufacture mainly of synthetic opioids, and in Australia, America, other countries with other healthcare systems where you're not necessarily filtered through your general practitioner, then patients with pain have gone to various doctors, getting different drugs from different doctors, and actually there's a higher incidence of patients dying from prescribed drug overdose than from illicit drug use in the USA. So prescribed medication abuse has become a big problem. So our first job as doctors is to do no harm. And although we're prescribing these drugs with the hope of helping the situation, the question is, are we often doing that? So tonight, I suppose the question I'm putting is, chronic pain and addiction, are we only seeing the tip of the iceberg? And I think certainly in a secondary care pain clinic, we probably only see the tip of the iceberg of patients with chronic pain, but even in primary care, we're only seeing the tip of the iceberg of how people take various drugs, from cocodamol, tramadol, opioids, and maybe some other groups of painkillers as well. So it was on this background that I got involved in a new guideline to try and look at the prescribing of opioids, and to try and give a framework which healthcare professionals could use both in primary care and secondary care. Because unfortunately there's not a good predictive test as to whether somebody's pain will respond to opioids. You can't say you've got pain X, it definitely won't respond to opioids, and you've got pain Y, it will. There are national guidelines, there are international guidelines which are very good, but we wanted to bring out local guidelines which were a bit more specific about the drugs to use and the dosages to use, particularly for the opioids. And one of the questions that came up is who's going to undertake the concept of an opioid trial, and who's going to monitor it. So when we're prescribing opioids, what the guidelines suggest, which is not always what happens in practice, either in the pain clinics or in primary care, is that we should have a good discussion with the patient about why it's not an act of desperation that they're going on opioids, but we're using this group of drugs with a purpose, and if these outcomes which are detailed there, a reduction in pain or an improvement in their function, aren't met, then it's not a long-term trial of the medicine. And I think it's easiest to have that conversation at the start of prescribing that group of drugs than when they've been on them a year, 2 years, or 3 years. The guidelines talk about having a monitored opioid trial over a period of 6 weeks, which again is an approximate timescale, but again that would be made clear to the patients. And there should only be continuing prescription if there's definite benefit and not side effects which outweigh the benefit from the medicine, and that there should be timely reassessment and ongoing monitoring. Now, there are various, when you're making that decision as to whether a particular patient is suitable to have an opioid trial for the non-malignant pain, then sometimes there are certain factors which make us much more cautious about thinking it's a good course to go down. And apart from your own gut feeling as a clinician and with your knowledge of the patient's background, there's also various tools which are used, but the one that we came down on recommending was the opioid risk tool, which gives a simple numeric score for different factors from the patient's history to allow you to give either a low risk, moderate risk, or high risk of them developing dependence and addiction problems. And then for ongoing assessment, and I suppose that you then put that patient into a category where you decide either yes or no, we're going to do this. And if you are going to do it, then you're thinking of the degree of supervision that you think is required of that patient for them to be safe with that medication. I don't actually have a slide of the tool that is used for assessment. This pain and dependency tool, the PAD tool, is the one that we would use for ongoing assessment as to whether the patient was running into problems with their medication. And the idea is that if there's no benefit, that the opioid is reduced and stopped at the end of the 6 to 8 week period that it's been tried. And I'm not going to go into the details about the rest of the guidelines, that's really the focus of this evening. But one thing that's highlighted in the guideline are the groups of patients for which we would suggest that it would be appropriate to have closer monitoring, and that's patients with mental health disorders, depression, anxiety related to their pain, a previous or existing addiction to any substance, or similar problems in their family. Now, that's a lot of patients, that's a fairly high proportion of patients that we see in the pain clinic, and that is what led us on to thinking about whether we were actually helping these people or addressing some of their problems. Also, there's a slide saying for primary care clinicians when they would consider referring for a pain specialist to the pain clinic. And that's an area that we are interested in as to what triggers somebody being referred to the pain clinic. And certainly problems with drugs and problems with people being on what would be considered excessively high doses of opioids or other medicines is one of the reasons why people are referred to us. But what I would say is what do we actually, or can we actually provide in the pain clinic for somebody who is considered to be on far too high a dose of whatever medication? Do we actually have the resources to actually make, to support them to reduce the dose if they're engaged in that process? And the answer is no, we don't. We aren't able to see them often enough or give them enough support, which is kind of why we got into discussions with the community addiction team, and we've just started over the last few months having 6 weekly MDT discussions of some of our patients. What's the evidence? The evidence is that there's lack of evidence for if you have identified someone who you think is at a higher risk of abusing their medications, whether keeping a closer eye on them and seeing them more frequently and supporting them actually is a useful thing to do. This is a study from Pain Journal in which they identified 42 patients who were deemed to be at high risk of opioid misuse, and 21 were in a standard control group and 21 were in the experimental group, who had monthly urine screens, a compliance checklist and individual and group counselling. And then they had 20 patients who were deemed to be low risk for opioid misuse, who were in a control group. And down the bottom there you can see that aberrant opioid use was identified in almost 74% of high risk groups treated with standard care, but only in 26% of patients who were in the more active experimental group. And that compared roughly with the incidence of abuse, which is still quite high, in the low-risk control group of 25%. Another paper from Pain Medicine, predictors of resolution of aberrant drug behaviour in chronic pain patients treated in a structured opioid risk management programme, which is, is that something that we should be able to deliver? And they looked at 195 patients referred by primary care to the opioid renewal clinic. It was pharmacy-led, I think that means pharmacist-led, I think. And there was strict adherence to the structure of the study, with frequent visits and giving of the opioids in smaller doses with counselling and education and urine testing. And 89 patients, which was 45.6%, resolved their aberrant drug behaviour in one year. But patients, and I don't know why this would be, patients with cocaine abuse were 5 times more likely to fail. And the more complex their chronic pain, the lower the chance of them being able to resolve their aberrant drug behaviour. So, in summary, that was kind of my perspective of the group of patients that I come across in my practice in a chronic pain clinic. What is the size of the problem? Well, we might get some information about that this evening. We're in the process of gathering evidence. And later on this evening, we'll get the perspective of an addiction specialist who sees lots of patients with addictions problems from illicit drug use who also have chronic pain, and some of the difficulties of managing that situation. And just for you to be thinking about during the talks, is this leading anywhere? And we're very open to ideas and thoughts as to whether, or in what format, any collaboration between the pain clinic and addictions, is it needed? And if so, what form should it take?